Thank you. That's very kind and nicely short. So I'll start with some disclosure. So I have, over the course of my career, come up with a bunch of tools, including clinical frailty scale, and to prevent unauthorized commercialization of them. So people aren't trying to sell them back to me. We ask users to agree not to change, commercialize, or charge for them, but they're otherwise free with permission. I have a wee company that still exists called Ardea. It was originally founded to look at better ways to measure outcomes in Alzheimer's disease. We don't do any work in frailty. And now we're sort of edging into advertising. I'm also the editor-in-chief for the 9th edition of Brocklehurst's textbook of geriatric medicine gerontology, available soon in Amazon near you, or so we hope. So my objectives today are to understand why frailty challenges contemporary healthcare, especially acute hospital care. So the part of the motivation for this work I'm going to show you today is because with Nova Scotia Health, we created a thing called the Frailty and Elder Care Network. And we've begun in acute care hospitals because that's where there is a lot of extreme need. There's need everywhere, but we thought we should start with something in which we could imagine an early win that would be useful to folks. So that's the rationale for that. So I want to review some of the steps that we've taken in the Frailty and Elder Care Network, and I see that some of my colleagues are online for this, to improve healthcare for older adults. And because where we work, geriatrics is not completely well understood, not like it would be in the UK, I've tried to boil it down to something that's comprehensible, and I found that a few numbers help people understand what motivates geriatrics and what it is we aim to do. And those 4 numbers are 75, 72, 5, and 2080. So let's see about that. And I reviewed a lot of the stuff in a paper with Day Kim last year. So let's begin by what is frailty. Famously, there are various ways to define it, various ways to operationalize it, and so on. But my take on frailty is that it's a vulnerability state, and it arises from the accumulation of age-related health deficits. So it's intrinsically related to age. And as deficits accumulate, the ability of any organism, I mean, we're concerned with humans, but this appears to be very broadly generalizable, the ability to resist stress, which is what we mean by robustness, gets worse. And so there is damage which arises more frequently in the face of stress. But so too is the ability to repair that damage, which is my understanding of what resilience is. And the way that we have attempted to model it, that's where resilience and frailty fit. It's not that one is a happier topic than the other one is a sad topic. It's about, if we want to understand aging, we need to understand these terms. So 75 is the first number to become comfortable with. And why is that? Well, here are data from Sweden, from the Swedish Fracture Registry across the life course, starting at about when aging starts, which is roughly the age of 15. We can talk about why that's the age, but in any event, for now, you'll note that hip fracture sort of grumbles along at a low rate and then takes off. And what age does it take off at? 75. Here's the estimated cumulative risk of dementia in older Canadians. And when does that take off? 75. And what about end-stage kidney disease? 75. Congestive heart failure, 76 or 77. COPD exacerbation with the current admission, a bit younger, 71 or 72. But as a general proposition, all of the diseases of old age increase at the age of 75. And what that means to a system that has succeeded and done so well in treating people with one thing at a time, suddenly they are faced with people with many things wrong. So let's imagine, as far as I know this is not true, there's a specialty called the left upper lobe of thyroid, and you're a left upper lobe of thyroidologist, and it's taking you 12 years past undergraduate medical training to be like the left upper lobe of thyroid person. And then someone comes along and they've got a left upper lobe of thyroid problem, but they've also got atrial fibrillation. They've also got some COPD, and there's something, for some reason no one understands, been hard to get their anticoagulation straight, and so on and so on. And you think, look, that's fine, but I can help them with this. And for a long time, we could get away with that. But the demand of patients with diseases is so high, and the fact that the diseases accelerate at the very age when the thing you're interested in is so big means that we have to have some means other than punitive name calling of dealing with people if many things wrong all at once, including things that we're most interested in. So here's how to think about this. So these are data from Canada. On the x-axis is age, and the y-axis is the degree of frailty using a deficit accumulation approach. And it's worth reading through the top a bit. The mean yearly rate of deficit accumulation, or the mean rate of aging, is at 4.5% per year. And this is illustrated by deficits that we can see in 8 two-year waves of the National Population Health Survey. So the black line is the average degree of frailty. And as you'll see, that increases with age. So that's not much of a discovery, right? The older people are, the more likely to have things wrong with them and more of them. But what makes frailty so interesting is this bit. The variability also increases with age. So the older someone is, the less meaning their age has for them. So over against people say, well, age is just a number. Yeah, the number is sort of informative for the group, but it's less informative for the individual. So look at pneumonia, a 20-year-old, if you can imagine such thing, they'd never come into the hospital. All looks about the same. The ones who came into the hospital would very commonly be people who are technically frail. They have many other things wrong with them. Otherwise, who brings a 20-year-old into the hospital with pneumonia? Although with the resurgence in some of the group A strep, we're seeing that. But as a general proposition, it's after the age of 75 that things get really interesting, where age means something less. And this is not just in things that we can see. So here are data from the Howlett Laboratory at Dalhousie University, and full disclosure, Susan Howlett and I've been married for 41 years. So so I know these data well, but I believe in them too. And so Susan, for a long time, for her career, has worked in various animal models. These are data from mouse and rat models of heart issues. So the way before they had the contractor frailty that this would be reported is in the adult rodents. This was how whatever they're interested in would be distributed. And because they're proper scientists, test tubes and stuff, and electron microscopes and really clever things, they would talk about the distribution of whatever it was they're interested in the adult mice versus the aged mice. And I just want to underscore this point. They started with mouse echocardiography. So what is the left ventricular end diastolic volume? And it would be distributed somewhat like this, but the work has gone on and on and on to look at calcium release from the sarcoplasmic reticulum within the myocyte. But all the way through from the size of the myocytes, the force of contraction, all the way through that, you see these types of distributions. So you can see there's variability in the adult mice, there's variability in the aged mice, but generally the aged mice are have lower whatever the thing you're interested in than the adult mice do. But let's look at those same data now presented by the degree of frailty. And you can see that things make a lot of sense, that the mice that are older but are functioning well, they're actually, it's not just their heart releases, everything about them calculated in a frailty index has gotten better. So what is this frailty index, you say, that we've spoken about? It's the number of things, the number of deficits that a person or a mouse or a rodent or whatever it is has wrong with them, divided by the number of things that you counted. And because we're always working with existing data sets, and because people collect data typically for reasons other than calculating a frailty index, that number, the denominator, varies. But amazingly, the ratios have about the same meaning. So the frailty index as a number has about the same meaning wherever you find it. And it turns out that in the expression of age-related illness, this turns out to be particularly important. So now I'll show you some human data from work that we did in collaboration with David Bennett at the Rush University Studies in Chicago. where he's got a world-class collection of community-based autopsy studies. And we look at, on the x-axis, Alzheimer pathology, and on the y-axis, the chance that people had dementia. So again, when I was a boy, I was taught that Alzheimer's disease could only be definitively diagnosed at autopsy, and autopsy was the gold standard, as it was for all of neurological disorders. But it became evident pretty quickly that wasn't true. And so ultimately, by 2019, with a great young then PhD student, Lindsay Wallace, we were able to work with Dave Bennett's data to show this. So you can see, well, let's just take this middle group, because I'm a Canadian, we always do, the middle way. If you have very little pathology, there's a low, and not a zero, but there's a low chance to have a diagnosis of Alzheimer's dementia. This is Alzheimer pathology. But as the degree of Alzheimer pathology goes up, so does the chance you'll be diagnosed with dementia. But you can see it seems to vary in some important way. And you won't be surprised to hear, with the lead-in that we've had, that these are degrees of frailty. So this is what low frailty looks like, an intermediate degree of frailty, and a high degree of frailty. So even people with very little Alzheimer pathology met the clinical criteria for phenotypically characteristic Alzheimer's disease 60% of the time if their degree of frailty was high and they died over the age of 75. If you had a whole lot of pathology, it looks like even very fit people will succumb. But generally, statistically, most of us live in the middle of things. And you can see that in the middle, there's a very important gradient in the risk of dementia. And it's graded both by pathology, but chiefly by how frail someone is. So, and this holds for a number of illnesses, and we've reviewed the neurological illnesses in Lancet Neurology in late 2024, but it leads to this conclusion. Frailty is not a disease, but it profoundly influences disease expression. So 75 is an age at which the ologies stop working. The idea that you can go in and look at people with the illness you're interested in and forget about everything else, you will not get the outcomes that these folks need. So what you need over the age of 75, not in everybody, but in the people who are frail, you need a way to manage their complexity. And this is the genius of geriatrics, is the understanding of how we can manage pragmatically without a lot of math, just in a way that makes sense. It can be explained to everybody, that everyone can see what the complexity of frailty does. But to get there, we need to understand name and stage frailty, and we need to know when people are really, really ill, or when whole system failure lurks. Because if you've had any experience with a frail older person in the hospital, sometimes it's hard to know they're sick, and sometimes it's hard to know whether they're getting better or not. So one thing to take away from this talk is there isn't just frail versus non-frail. There are degrees of frailty, and how frailty manifests itself clinically changes as the degree of frailty increases. So this is taken from the clinical frailty scale card. It's a person who is running. This is the managing well. This is the icon, one of the icons for mild, very mild frailty, and so on and so on. And this is what terminal illness looks like in many people. In others, they're still able to function somewhat. But in older adults with frailty, this is when they're at the stage of very severe frailty, which is more or less the terminal stage for frailty itself. And the size of the icons is meant to illustrate here the chance that an older person you see in hospital will fall into whichever category. And I'll show you some data in support of that. So here's the clinical frailty scale, and what it does is it lets us to grade the degree of frailty. And importantly, when someone's coming to the hospital, what we're interested in is their baseline state, what they're like 2 weeks ago. So let's just go through a couple of examples of why this is so important. So CFS level 4 is living with very mild frailty. So this marks the earliest transition from complete independence. So these people are not dependent on others. Sometimes they have symptoms which will limit their activities. Commonly, they complain of being slowed up and are being tired during the day. And so you'll note that, not by coincidence, this also incorporates frailty, 3 of the 5 items from the Fried Frailty Index: fatigue, motor slowing, and dependence in the highest orders of functioning so more than the IADLs. I tell people that the part of Newfoundland that I come from in Canada, I come from Newfoundland, live in Nova Scotia or New Scotland now, but I'm originally from Newfoundland. Where I grew up, it would snow a lot during the winters, and it was a thing I now understand the significance of. At a certain point, it was important to shovel the snow off your roof, unless your roof was very, very strong. The chance it would cave in or stove in, as we say, would be high. And when a man got to the point that he couldn't, in the middle of the winter, take his ladder out and take his shovel up and go up and shovel the snow off his own roof and have to get his son to come do it, that was a stage that things weren't exactly right. So, guys, 80's pretty good, but yeah, he had to get Billy to come over and shovel the snow and such. So it was a way to understand that would manifest in real life. Though probably shoveling snow off the roof in the middle of winter in Scotland would not be a sensitive test of very mild frailty, I'll wager. Here's someone living with very severe frailty, and they're completely dependent for personal care, and they're approaching the end of life. So there's a big difference in not being able to walk without assistance and not being able to feed yourself. So there are definitely grades within that too, but that's severe to very severe frailty. And when it's very severe frailty, we believe they couldn't recover even from minor illness at baseline. So this would be what they're like 2 weeks before they got ill. So if we're going to now spell this out about what's going on at the age of 75, it's that we need not only to know just when whole system frailty lurks, but we have to find an alternative to what in North America is the problem list. Problem number 1, 2, 3, 4, 5. And I remember early on studying at a famous American university with a group of people who look at frailty, and they played the game of, well, my problem list is longer than yours. You had 18 things, I have 24 on mine. You didn't get the hysterectomy she had when she was 21, right? So people without knowing what they were doing or without getting the point isn't to have a long list of things. The point is to understand what's wrong with the person now. And in those days, the fashion was to soap the notes. I'm not sure if you have that in Scotland, but to soap the notes means for each of the problems you identified, subjective, objective assessment plan. And I'll show you why that turns out not to be a reasonable thing, and why a comprehensive geriatric assessment is what you need, not a problem list, and why when you get this in place, care planning often flows from that. So the clinical frailty scale helps us understand the patient's baseline, like what they were like 2 weeks ago. And this is I'm just paying attention to the time, so I'm going to romp through this. This is Bob, and Bob has shown up in the emergency department, and what's going on with Bob? Well, it turns out that he's confused, which in his case was delirium, and he can't walk well, which is impaired mobility and balance. He can't care for himself, so it's functional impairment. So the big question is this new? Is this new? And it turns out that in Bob's case, there wasn't really incontinence and there wasn't social abandonment, because a neighbor saw him sitting on a park bench and was so amazed at what was going on with Bob, because Bob would normally not be sitting on a park bench at 7 o'clock in the evening, that he just put him in his truck, drove him into the wee hospital in the small community in Nova Scotia where Bob lived, and he got Bob treated, because everybody looked at Bob and said, oh my God, what's wrong with Bob? Now, before I go any further about this, I want to stop. I'm going to talk almost exclusively about frailty. It's not because there aren't other things that are important. Here's some data from a bunch of people that I saw in the hospital done with this brilliant young geriatrician colleague who just finished her PhD and is now, I think, in her 10th or 11th postgrad year finishing geriatrics with us. But she did something really clever to look at the impact of frailty versus social vulnerability. And so gray is the size of the regression coefficient associated with various adverse outcomes, and having to do with frailty. Orange is what it is is social vulnerability. The wee star tells us whether or not this is significant or not. So in Canada, at least, being admitted to hospital is chiefly a function of the degree of frailty. Social vulnerability plays only a small role. But the chance of having an extended stay is mostly related to the degree of social vulnerability. And to become this terrible word we have, ALC, alternate level of care, right? They're blocking the beds. They're all looked after. Everything's fine. They just won't go home. That's a function both of frailty and social vulnerability. Death in hospitals, chiefly having to do with frailty. And being discharged home, being protected against being discharged home, is a combination of both of those things. So social vulnerability is clearly important, but we only have a certain amount of time, so we're not going to spend more time on that now. So this is Bob on his park bench, and when anyone, a neighbor knew he was ill, because this is what Bob was like 2 weeks ago. And Bob was a retired 83-year-old man who moved back to the wee community that he had come from, and he was very successful. For the last 2 or 3 years, he looked after his wife as she died with terminal dementia. But even when that was going on, because she wouldn't get up early, Bob would get up and run every morning. And so the people in this small community, they all knew about Bob. They all knew about how great he was. In fact, when you hear people talk about it, you think they were out doing the run themselves at 6 o'clock in the morning, but that was Bob's thing. So when he couldn't do that, when he's delirious, confused and such, it was clear that he was ill. And Bob ultimately was diagnosed early with gram-negative sepsis, medevac to the big teaching hospital, a helicopter ride away, and came back to do well. And Bob's story for his level of fitness is not atypical. So here are data from these 800 or so patients that I saw in the emergency department, not as a geriatrician, not as a geriatrician, but I was there in my role as a general internist doing take. And over the course of a few years, I'd had data on, it's now over 1,000 folks, and we followed them through. And this is a clinical frailty scale score that I did myself, so I'm confident with, but also a frailty index score. However it goes, we grouped it in relation to the solid line, which is people who are acutely ill, Canadian Triage Assessment Scale, CTAS of 1 or 2, and that's the solid line. These are the dashed lines, but you can see the worst thing is to be a clinical frailty scale score of 7 to 9 and be acutely unwell. There was a lot of mortality there, and the best thing was to have a clinical frailty scale score of 1 to 3 and a CTAS score of 3 to 5. Confusingly, one's like golf, the other one's like hockey in terms of the interpretation of the score. But you can see that acutely ill or not, across the grades of frailty, there was an increase in the risk of death. But I want to draw this to your attention. Most of the mortality in the people who were going at the highest risk of dying was happening early. Most of it was happening early. And so it's the idea that early mortality happens that should motivate what we're trying to do, but also help us understand what it is we're seeing. So 72 is the amount of time that we have to turn down someone who's presented at a hospital with acute illness and frailty. So all of us have heard of, or I'll bet all of us have heard of, the golden hour of trauma. Very few of us have heard of the golden 72 hours of acute illness in a frail older adult, but it's true. And so we've got 72 hours to turn things around. And this is a matter of physics. This is entropy. This is falling apart. And it takes a lot of energy to restore things that are falling apart. And physics doesn't care if you spent the first 36 hours in the emergency department because there wasn't a bed in and no one was there to help you because we don't do that in the emergency and blah, blah, blah. This is the challenge that we're up against here. So what I'm saying is not controversial. There's a whole book, Silver Book 2, freely available online through the British Geriatrics Society, and look at the subtitle, Quality Urgent Care for Older People. And that has a lot of the principles and it's spelled out the things to do, but I just want to draw your attention to one thing here. And this is the impact of, here we go. This is the impact of how an older person moves in bed. So let's just look at this line first. These are the outcomes. This is a chance of being discharged back to your own home as opposed to being sent back to the referring hospital that you came in from, or of dying or going to long-term care. This chance of being discharged home if you show improvement in how you move in bed. And so that means you have to know how people move in bed when they're ill, and we'll talk about that now. But just right now, the contract. The person can move up the pressure points versus the one who can't. The person can start to pull themselves up to sit when you ask to listen to their chest versus the one who can only move off their pressure points and so on. There's ways to grade bed mobility. And you can see that, again, a lot of the stuff that's happening is happening within the first couple of days of hospital. This is the golden 72 hours of a patient's stay. And this is why the Acute Frailty Network at NHS England said we have to look at bed mobility as how we're going to do things. And some of the early work of validation was done in Scotland. So over against this group, which has a 5% mortality at 30 days, because when people come in, they're ill. The group that got worse, most of whom died early, has a 75% mortality at 30 days. So it's really, really, really important that we pay attention to what goes on in the first 3 days, because that allows us to understand what's happening with this patient. And so I'll be telling you a little bit about the early mobilization project that we had or have at Nova Scotia Health. And one of the, I'm in another couple of weeks, I'll have the final numbers of this. Right now, I've only got the qualitative data and some early counts. But one of the emergency department nurses at one of the hospitals that was an early adopter of the early mobilization strategy said, I'm seeing more people up and moving than I have in my whole 15-year nursing career. So it makes a difference to the entire ward when you see what happens as you start to mobilize people early. And there are data that show that frailty can be remediable, improved specifically by exercise. And this is an in-hospital intervention trial published in Aging in 2022. This is the people who had the early intervention. This is the people who didn't, just had the usual care. Green is better, blue is about the same, yellow is worse. So you can see the chance of being green is much better in the early intervention versus the control. The chance of being much worse is much lower in the early intervention being control. And there's this group who stayed the same. The chance of still being the same lower in the early intervention group. So this is what we're aiming for with the early mobilization data. I'll show you a few things right now. This is the distribution of the age range. It meant to be for people over the age of 65, but as people got more more skilled in this, and they saw younger people struggling, and some of those crept in, but mostly 75 to 85, which is the target that we had, a small female preponderance. This is sort of where they came from. This is the length of stay that they had in the hospital. So, we get most people out within the 14 days, and hopefully soon we'll have the data to show you. All of this is more with the early mobilization group, but I don't have that quite yet. We started off by targeting clinical frailty scale scores of 4 to 6. We didn't want to target 1, 2, 3 because those people are going to go home anyway, no matter what you do. And at the start, we didn't have the skill to do 7, 8, or 9, but we thought, let's get good at the 4 to 6 and see what goes on from there. And what we're hoping is that as we show people what older people moving in bed when they're getting better looks like, this becomes a way to start to recognize the common geriatric syndromes. Ooh, like this person was doing well for a couple of days, but now suddenly they're very confused, and now they're not mobilizing as well. And so we put in training programs so that when the mobilization folks talk to the nurses and say, Mrs. Smith seems confused, and that they know that is likely delirium because they weren't like this a couple of days ago, and so on and so on. So we're hoping to get this as a signal of the overall things that need to be done for that patient. So we had more than 5,000 patients over the first year. In the early data, only a third were referred within 48 hours, because one of the things that we hadn't properly tackled was the reluctance of people to mobilize patients, even with a mobilized patient there, without them being cleared, quote unquote, so they could be covered, quote unquote. So they had to see physio first. And part of the motivation of this work was it takes a while to get to see physio, and physio wasn't available 7 days a week. So insisting on the person being cleared by physio first, and the physio can't just go and look. Well, they could go and look, but they can't do that. So this introduced a delay. And so this is an example of how well-intentioned work, where you think you've got it all done, you've spoken to everybody and done all the stuff the implementation science says, it doesn't work if there is a part of the curriculum which is hidden, which is, I'm afraid I'm going to be sued in an American court in 10 minutes if I do something wrong. So we're trying to tackle that, and I'll show you more about that in a few minutes. I'm just going to skip over this because I'm cautious of my time. So we've talked about the first number, that was 75, the age at which all diseases of old age take off. 72 is the amount of time that we have to turn things around. Partly what we need to do in that 72 hours is we have to improve our whole system failure indicators. So lack of mobilization, people slipping in, not slipping and falling, but not mobilizing as well as they had from one day to the next, particularly early on, that's a big signal. And we need to be able to incorporate that in terms of an action about what we do. Again, I'm not telling tales out of school. I'm sure no one will be surprised to hear that some of the things that we tried to do about that to indicate how this was to a geriatrician an emergency didn't have the same resonance. I tried to say to people, if you're on a surgical ward and you walked in and you're there to do the mobilization of the patient, and you notice that they couldn't get up because they'd thrown up bright red blood, we'd expect you to go and say to the nurse looking after that patient, Mrs. Smith has in bed 14-2 has thrown up bright red blood. That would be an event. And no one would doubt that that was the case. So why are we doubting when the person doing the mobilization, why aren't we having the same urgency attached to it when we say, yesterday they got out of bed with one person minimal assist, and this morning they can't even sit up. That is an emergency, and we have to get that understanding there. So I want to come to the number 5. And so again, if you've, I'm not sure of how the note working works in Scotland, but where I work, we still have the problem list, 1, 2, 3, 4, 5, 6, 7. And to a lot of these is now attached in the name of evidence, a clinical practice guideline. Oh, if they got pneumonia, you should do this, this, and this, this. They get kidney failure, do this, 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 and that. And if they've got heart failure, this and that. And by the time you hit 5 things wrong, if you apply 5 separate guidelines, by the time you hit 5, you're guaranteed. One of the things you're supposed to do for condition 1, you're not supposed to do for condition 5. And so we need to have a way to adjudicate with the chaos. And what we do in geriatrics is we look at the key functions, the things that human beings do. What do we do as human beings is, the human thing. We stand upright and walk. So mobilization here is really important as a way to understand what's happening with this patient. And are the things I'm going to do, will they help the mobilization or not? In the same way, another thing that we do is pay attention and be cognitively intact and interactive. Now, that is often tricky if you don't know the patient to know where they're at. But if you do, there's some tricks of how to deal with that. So attention, concentration, and cognition in general, that's the thing we do as humans. The other thing that we do as humans is we have opposable thumbs. That translates into function. So looking how someone is functioning today compared with yesterday winds up being really important. And then there's social engagement. Are they with you today? They weren't with you yesterday. There was things kind of a fog, but they're with me today. That's what getting better looks like. And then we have incontinence and some of the other things that go with not being quite what yourself is like. And for that is, what is yourself like? Well, generally, what yourself is like is what you're like 2 weeks ago before all this happened. It's not some perfect marathon running thing unless you were a marathon running person prior to being ill. So we need to measure, pay attention, have this part of our conversation if we're going to understand, are these patients getting better or no? So looking at mobility, looking at engagement, looking at cognition, looking at function, is doing those. That's how we manage the complexity. We don't need to soap the notes. How do they subjectively feel about this, that? No, in general, are they mobilizing? Are they able to articulate in a way that allows us to know they feel about anything? And when we do that, we have the guts of the comprehensive geriatric assessment. So we've done a lot of work, and I've got that for questions about how we standardize the CGA and how we done it in a way that allows you to recognize patterns at a glance by the paper, because heart contraction is infinitely complicated, but any competent doctor can look at an ECG and in 2 seconds get the story of what's happening with this patient. So we've laid out the CGA form in a way that with a little bit of training, you should be able to look at it and say, this person must have delirium, or here's someone who's very ill, or here's someone who's getting better, and such. So what we're trying to have people focus on. They've got to get the information in, but they get the information in not because it's a ritual. We got to do the inner eye form, otherwise the nasty person will come and shout at us. No, we need this information if we're going to understand what we can aim for in this person. And so that's where the prognosis part comes in. So when you have the CGA form sorted out, if you realize that it's hard to make someone better than they were 2 weeks before they got ill, the care plan of what it is you're trying to get them back to, that baseline state, becomes much more easier to deal with than if it's a mystery, that if no one really knows. And if it's dependent upon information being handed over in some weird way, well, I've just been back off nights and so on. I only had this patient today and so on. Replace that with saying this person, based on this 84-year-old retired baker at baseline was CFS 5. That gives you a sense then of, with a very few words being spoken, a sense then of what they were like. And then you can pick out the 2 or 3 things that are really important for this person and include that in the routine handover. So that brings us to the final number, which is the 80-20. And the 80-20 number is, if you've ever done economics, you'll recognize this as the Pareto optimal state. But if you've ever been a high school principal or know one, you'll know that they spend 80% of their time on 20% of their students. And the 20% of students they're spending time on are not the ones who, which scholarship will they get? It's the people who are, are we safe in the building anymore? They're going to come burn it down and such. So 80-20 here, though, has a much more pleasant meaning. 80-20 means that, as a general proposition, any question the family member, 80% of the questions that a family member has should be able to be addressed by anyone about the care plan. Everybody understands the care plan well enough, and they've been around long enough to see how this thing works out, that when the daughter asks about the chance that dad can get back to doing X or Y, they've been in the team conference, they have some sense about it, and they can start to lay the stage for that. Say, well, here's what we've observed, X and Y and Z. Here's how that normally gets interpreted. And, let's get whomever, physio is really going to help you now, but as opposed to information where everyone's in the dark about what's actually going on about this patient, that's what we need to get away from. So the 80-20 rule is also called getting the maximum for the minimum. It also extends to, as a general proposition, 80% of the time, if someone has something, you can help with that person. There's enough interoperability that you could give a hand to do anything that needs to be done at that instant. And let me just give you an example that scars me still, is seeing a physiotherapist go get the nurse because the patient with Parkinson's they were trying to mobilize was drooling. And they apparently couldn't take a tissue and clean up the drool or some sort of a thing. In Parkinson's, in a like, how refined and understanding must you have of your job that in people who predictably will drool, particularly when you get them to work, that you can't deal with, you got to go get a nurse to. So we need to understand that interoperability is an important part of what we're trying to achieve, because our patients don't come as single discrete packages. They come with a bunch of things wrong. We should be able to manage a lot of the bunch of things that anyone have. The other thing when we're talking geriatricians is to say, will you please stop fetishizing the 2-hour CGA, because you've got to collect every piece of information, and trust the team members who've just done a cognitive test that that's a pretty good shot at it. If you go in and see it doesn't seem to match up, fair enough. But don't go repeating the mini mental state exam because only you can do the MMSE, right? We got to learn to trust each other. That's the important part of that. And that brings us to this topic, the dignity of risk. I don't know if you folks have heard about this particular term. It's used in a bunch of places. We found it has been extremely helpful at the Frailty and Elder Care Network. And there's a part of the Nova Scotia Health website called Dignity of Risk. And if this is new to you, I'd advise you to go have a look at that. Dignity of risk means respecting people's right to live their lives even with risk. It recognizes that daily life is inherently uncertain, and taking risks can lead to positive outcomes and quality of life, health and well-being. You say, well, yeah, who doesn't know that? Well, a lot of people might know that, but if you've been brought up on the hospital safety culture, oh, we can't do this, it's not safe, then you are denying people the ability to get better in important ways on a time frame that is likely to allow them to get home. So older adults who want to keep their independence, we know they want to keep their independence and autonomy more than being safe, even living with frailty, dementia, or disability. As a general proposition, they want to live their remaining years as freely as possible. If this person is exception to the rule, we have to accommodate that. But generally, so everybody's afraid all the time that they can't sit up because they might fall down, and treating them all as though bed is the best does more harm than good. And so the operationalization of this is we have education sessions talk about things like ageism, paternalistic attitude. The invidiousness of the safety focus, as important as it is, it can't be the trumping virtue, if you pardon the expression, trumping. And then we have to reflect all this through the personal values of the people who are involved. But our starting point is not that everybody's completely risk averse all the time. And so I just want to sum up by saying this. There's a continuum of fitness and frailty, and acute illness can compress it. So here's Bob out running. Here's Bob in the hospital bed. He wasn't quite as bad as that, but he was definitely, if you didn't know that he was a really fit person, it's hard for an even a really fit person. They can be fit and they can look buff, but most people who are fit at age 80 don't look buff. Remember, look at the guy here now, right? There's a bit of punch on him, and you call that a run? That's not a stride, man. I mean, but this is great for an 84-year-old to be out running like that. So again, we have to adjust our expectations for that. And then, frailty is not a disease, but frailty influences disease expression. I showed you before, if you've got a healthy body and a healthy brain, which is what this neuron is meant to get at, you have the lowest dementia risk. If you have an unhealthy body, or not an optimally healthy body, and a brain full of plaques and tangles, your dementia risk is high. But here's the new and revealing part, that you can lower the risk of the plaques and tangles if you're a healthy person to start with. So those four numbers, age 75, that's when all diseases of aging increase. 72 hours is the amount of time that we have to turn things around. So we need to have defaults that provide frailty-informed acute care. 5 is the number of items in your care plan in which it still makes sense to soap the notes, or which it no longer makes sense to soap the notes. And what we should do instead is look at the information that's gathered in a CGA and monitor cognition, function, mobility and balance, and social engagement. And 80-20 is how teams can share knowledge as we try and get to this idea of shared decision-making with families. That's why it's important that anyone be able to talk to the family, that they're able to get information wherever they find it. Where we're going with this in the Frailty and Elder Care Network is we're looking at scalable passive measures of frailty. We're looking at what's called primary care geriatric assessment, probably being called primary care frailty assessment. We're looking to make the CGA more widely used and readable. We're trying to tackle the ocean of frailty hostile culture by a steady drip of better methods, attitudes, and adults. My personal feeling in the North America context is that we've got to get the cool kids, which in the North America context are the highest paid ones, online, on side. And so we're seeing the evolution of things like geriatric cardiology and geriatric nephrology. I have a more controversial view that I think that there needs to be a discipline that knows enough physio and enough occupational therapy and enough everything that you can be a gero technician or some such, that you've got a wide range of competencies that allow you to do most things, but you may need specialized help with, or you're bound to need specialized help with some things. And maybe if we get around interdisciplinarity or transdisciplinarity by having people who are themselves multiply disciplined, that might be help. Actuarially, I'm coming at the end of my career. I'm not looking to end it, but I'm aware of how the numbers work. So I want to say thanks to this large number of organizations which have helped me, and particularly to the large number of colleagues and students who have been privileged to work with, some of whom I'm working with here now. Still, particular debt to my wife, Susan Hallett, and to my late colleague, Arnold Benitsky. I thank all of them, and I thank you for listening. Thank you very much. So let's, oh, that's very kind. I can't hear you, but I can see you. So thank you. I really appreciate that. Thank you very much. So let's get to questions. Let's keep the conversation going.
See us all standing there, Professor Rockwood.
Yes, I saw that. That's very moving.
Good.
Thank you.
Thank you so much for those pearls of wisdom and so many amazing sound bites, and maybe things that we can take back and look at what we were talking about earlier in our workshop. And I love that expression, adjudicate in the chaos. I think that's what we are all here to do. So we've got time for questions. Remember not to ask your question until you've got the microphone in front of you.
Questions or comments or objections. Lots of times we have really interesting discussion when someone is objecting.
Okay, over there, Alan.
Hi, thank you very much for a wonderful talk. I think Alan MacDonald, a geriatrician in the Highlands of Scotland, and I think we probably we probably have a similar issue to what you have in Nova Scotia, in that when we're trying to judge frailty, we could have people that are the same age that have vastly different levels of activity before they start slowing down. For example, people round Inverness are often less active, etc. But if they're in a small holding on the Isle of Skye, they might have sheep and cattle and hens that they're looking after. Does the level of activity, normal activity, matter when we're judging if they're reaching sort of the CFS scale 4, or is it relative to their baseline?
So that's a great question, much debated. So, and the Canadian answer is it depends. So there's merit to both views. So at a certain point, there are, if you want to judge on how someone is doing and what their baseline was like, you should stick as close as you can to what the descriptions say. So if this person is a CFS 4, then they should still be able to do most everything for themselves. But if you notice that there has been a decrement, then that there are things that used to be able to do they can't now. The critical question is, how long has that been going on for? Because again, it's entropy. And if someone is in their minds imagining a baseline of what they're like 2 years ago, but things have changed in the interval, it's an important part of the process of helping them prognosticate, of helping them understand their situation, to understand as precisely as you can what they've been doing as their ordinary recent baseline, and recent in weeks. And unfortunately too, our experience on the consult service is that if we've been consulted to see a patient and take them over, by which they mean please have them leave our bed, who was actually out going for a run 6 weeks ago, but 2 weeks ago they were languishing in the bed post-operatively, having had a stormy course, quote unquote, and a missed enterotomy, which is a phrase I've only learned recently. That means the surgeon nicked the bowel. Then it's going to be hard. It will take a lot of work to get the person back, even to where they were 4 weeks ago, much less their baseline of 8 weeks. So there's a lot of work that goes into understanding how much of someone's state is remediable. But as a general proposition, what we're trying to do is get as accurate an understanding of what they're like 2 weeks ago, and then if their baseline, what they're like before they came into hospital. And that delta is often very informative about prognosis, including, the universal geriatric outcome, being alive in your own home 1 year after the event. So it's not all good news, but it's not all bad news either.
Thank you. That's wonderful.
Rowan?
Hi there, thank you very much for your talk. My name's Ro Mollis. I'm a consultant geriatrician down in Ayrshire and Arran. I wanted to firstly thank you for that, but secondly, thank you so much for bringing up that dignity of risk bit, because for me, that's one of the most important bits at the moment. I'm a geriatrician that works between hospital at home, acute hospital, and preoperative assessment. And everybody's concept of risk in those 3 different places is entirely different. And I get that the individual's perception of risk can be somewhat combated by MDT discussions and, you know, a kind of collective take on of responsibility. But I wondered if you had any suggestions about how we can better deliver training and education and experience to try and get that concept across.
Yes, I have some ideas. They're not all without controversy. So I think the thing that scuppers a lot of the work we aim to do in geriatrics is the deadly combination of variable risk tolerance in the team members coupled with passive aggressive behavior. So you can see it in team conferences, and I've had the great privilege of, you know, seeing geriatric practice in many, many countries. And it's hard to miss passive aggressive behavior wherever you see it. But if you sit in the multidisciplinary team conference and you see that we're spending 20 minutes on each of the first 2 patients, not because they're the new admissions, they deserve a bit more time, it's because we're struggling to get agreement between person A in discipline A and person B in discipline B because they never agree. And so there's this little sniping that goes on, and you don't even have to know the language to understand that. And then you find that, oh, suddenly there's something that they've agreed on, and then everybody's is wanting to chime in about how, yes, we're all agreed this anemia is very bad for this person, you know, thank God. And then it all falls apart again. So the signs that I look for is, do you wind up having the last 7 patients crushed into 3 minutes in total? Do you find that after the team conference, there's little groups of people out in the hallway afterwards trying to come to get together things that weren't covered there? Did you get the long silences with the exasperated and the crossed arms and the, you know, bilateral olecranon heavenward ba sign? When you see that, you realize that this is not a team that's going to find it easy to come around on understanding what the risk tolerance is. And if you don't have a way to adjudicate it, what happens is you default to the most risk intolerant person in the group. And so there are techniques that allow that to be less likely, one of which is to have a timekeeper who's the chair, and their job is not to chime in, their job is simply to announce, you know, we have 20 patients this morning, and that's going to mean the first 4 admits are going to get 11 minutes each, and everybody else is going to get 6. And someone says, you're 1 minute left to go. And at the end, whatever is not done is relegated to the end. So strict timekeeping in a really short period of time, will allow the discussion to become more productive, particularly if you couple it with the rule that you only speak to disagree. And because that's the opposite in Canada, you know, we're great at agreement. Oh my God, we're ever good at it. But we're not very good at disagreement. And if you only speak to disagree, then there's no need to talk. Everyone agree that anemia is bad. The first person who said it, that's fine. And where you'll see this turn up is on things like mobilization, and the physicists say, "Oh, she's doing so well," and you know, walking backwards on her heels and, you know, twirling and such. And the nurse may say, well, yeah, maybe with you in the gym, but with me, it's ringing the bell 15 times. She's the Queen of Sheba looking for the servants to come in. So that becomes really informative disagreement. It's not, I don't like you. It's informative. You're seeing something I'm not seeing. Let's figure out, because now there's a disability gap that we're seeing, and how do we remedy that, and which are things that people know how to do and such. So it turns out that the art of the multidisciplinary team conference is something that I don't think we spend enough time on, and the acknowledgement that there will be variable risk, and the acknowledgement that passive aggressive behavior is not the way to deal with that. We should discuss our discomfort at the level of risk and express why we think that's so, and then allow the wisdom of the group to help steer us. Those are the sorts of things. But I see that Karen Nichols is with this too, and she is an extraordinary person with a vast background in healthcare, and the ability to get tough conversations had and get awkward things done. So Karen, you had your hand up.
I didn't have my hand up, but I'm happy to jump in. Is my hand showing up? Interesting. Hi, everyone. I'm here in Nova Scotia with Ken. We are happy to share the resources from the Frailty and Elder Care Network and provide a dignity of risk overview for you, because we have developed very intensive programs that we are delivering to physicians, our clinician groups, as well as direct care staff, 3-hour, 2-hour, 1-hour workshops, which really get to the meat of the dignity of risk principles and helping direct care staff, look internally and look at their own value sets around how they care for older adults. And we're very, very well received across the province. So we're happy to share and even come and, give you a session virtually, as well as, talk to you about the resources we've developed, frailty, like naming, staging, and managing frailty. So we've got a number of resources that we're happy to share.
Well, thank you so much. That'd be really helpful.
Yeah.
So we're just coming up to times. Anybody got one more question? Yeah.
Hi, Professor Rockwood. Thank you very much for today. My name's Caris. I'm an AMP for older people in the Ulster Hospital in Northern Ireland. And one thing that we have noticed over the last 8 months, we started up a frailty intervention team, and we would go down to the emergency department every morning and commence a comprehensive geriatric assessment following screening them for frailty. One thing we've realised is there's a lot of defensive medicine, and part of my role will be doing advanced care planning, best interest discussions following a CGA. How is it where you are? Do you find it's defensive medicine also?
Yeah, so we do see a fair amount of that. Disturbingly, too, what we're seeing is the growth of the hospitalist services, in which people who are not specialists in medicine are being asked to look after some of the most complicated patients that we have. Why is that? Because they're old and frail, and medicine itself, is still stuck in that adolescent phase. This isn't fair. I didn't sign up to that. I don't do social work, and so on. And no, you have a skill set that this person needs, and the fact that you have to take into account the other things someone has wrong with them, and not leave a set of orders that you are the standard orders for this. That's not their bad, and we have to have some way that we can adjudicate that. And as I was saying, that's part of the reason I'm keen on things like geriatric cardiology and geriatric nephrology and so on. It's an outward and visible sign of the realization of even the cool kids. They've got to manage these people, and they need to be managed in ways that make sense to them as cardiologists, but also to make sense to them through the geriatric lens, as we say. So, and I'm envious of you, because we're just starting our Frailty at the Front Door schemes here now, and it sounds like you've got something going that's quite worthwhile.
Great, thank you. Before we close out, it's Chair's prerogative, so can I ask you one question? You've been in this game a long time, and that's not being cheeky, but I'm curious as to, is there something you've changed your mind about?
What a great question. So there's 2 or 3 things that come to mind straight away. I used to be extremely skeptical about medical aid in dying, but a large part of my practice is patients with fatal neurodegenerative disorders. And I was also influenced by discussions that we had with community. It was clear that the community didn't trust us. Didn't trust the healthcare system to have their best interest at heart. They trusted us to intubate someone even if they'd said that was not what they wanted and such. So there's a really important need for dialogue and everything around that. So if you'd asked me 10 years ago what I would be least likely to change my mind on, I would have thought it was that. I remain a big believer in acute geriatrics, but I've seen pushback against that, where people have confused the amount of time that it takes to get a CGA done with whether that information is worth collecting. So I haven't changed my mind on that, but I very much changed my mind to say we should recognize what an obstacle all the information gathering for CGA is, and figure out ways to simplify that for people who are not geriatricians, and present it to them in ways that they can contribute to their particular part of information, and figure out ways that we can make the process of interpreting CGA much easier than it is. That's a change. I look on trying to democratize the CGA to make it more accessible, but that's different from if you think it's the key thing that you've got, and it's your thing. It is our thing, but we won't get far if we can't share it.
Mm-hmm. Wonderful. What a great way to end. So it just remains for me to really thank you so much for giving Scotland an hour of your time. I think those pearls of wisdom will percolate through everybody. There's a lot of nods in the room. There's so much there that we can draw from. I think I took a photo of every single slide. But we're going to take
I think
those.
we sent you the slides.
Oh. And also just to say the recording will be there for you to dip back into so you can re-listen to things. So thank you so much, Professor Rockwood, from everyone here in Scotland.
My pleasure and my privilege. Thank you very much.